Hi, I'm Dr. Philip Macmillan. Thank you for joining me again for another update with regards to what's happening in the news. I think it's important for people, certainly my subscribers, to be aware of what's going on, and I try as best as possible to bring the latest news and science in front of you, right at your door. So I hope you appreciate it. Now, what am I talking about? The science has changed, but I am still right. I want you to understand that. It's absolutely critical. No matter what I do, I am right. What am I making reference to? I am making reference to the fact that there's been a change in the JCVI. I'll show you this here. This is the JCVI advises on autumn COVID-19 vaccine booster. This is in the UK. That's the Joint Committee on Vaccination and Immunization. Okay. So they have made a press release on the 25th of January 2023. So we are today on the 26th of January. So this is just a day later to keep you updated. So in the UK, they have made a decision effectively that they will no longer, after I think the 15th of February, I'll have to check the statement to make sure, be offering boosters, so COVID vaccine boosters, to people who are under the age of 50 and don't have very specific comorbidities. Now, I guess that's a good thing. Well, for people who have taken the booster vaccine, what would they be thinking? Is it that they were right to take it? Is it the timing that has changed? What has changed between now and then? So, actually, they have given some insight into what has been happening. And so they made the point that since they had high uptake rates for the third booster in December 2021, what they found was that further uptake was less than 0.1% per week since April 2022 in all eligible people under 50 years of age. So even the uptake of the primary vaccination course, which has been widely available since 2021, has plateaued in recent months in all age groups. So in effect, their reason is largely because they're saying people don't want it. So because people don't want it, I guess that's a good reason to stop doing it. Shouldn't it be because it brings benefit? Is it that maybe the risk benefit has changed? Is it that they perceive that now that enough people have been boosted, therefore we have hit the target of herd immunity in the UK, and that way we don't longer have spread of the virus? Well, I'm sorry to say the virus is still spreading. So that can't be the reason either. It's important to note that they haven't completely taken away the offer. So they do have some patients that they would still be targeting, and they are preparing for their autumn booster dose. And so they are looking at people who are over 50, and I'll show you this here again. So they are looking at, for a smaller group of people, that's here, such as those who are older and those who are immune suppressed, an extra booster dose in the spring, that's now, should be planned for. Outside of that, they are looking to change when they will be doing it for the autumn. That's the next time that they'll be doing it. And I think the date is the 15th of February, if I remember rightly. If you can look at the note to see if you are in the UK to understand what has been happening and why that is so. So the important bit as well with regards to the science, and this is why I have always said, and I have been challenged for it. I lost my place on LinkedIn for asking hard questions about why are we doing what we're doing? Is it actually based on science or is it based on politics? So I had simply cited some of the information, and I'll show you here. This is what I used as my judge. This was a paper that was published in 2021. Underlying medical conditions and severe illness among 540,667 adults hospitalized with COVID-19. This was March 20 to March 2021. So this was looking at people who weren't largely vaccinated. And what did they find when they did that? When they looked at the details on this here, among the technically 4 million people, of which 540 were hospitalized with COVID, 94.9% had at least one medical condition. And so my argument had always been, you know who is your high risk. You know where they are. You know what the conditions are. That's where you target. If you're going to be doing a procedure that needs emergency use authorization, target your most vulnerable. And all the data told us who that was. And it wasn't healthy people less than 50. Why did we change at that point when we knew this data at the beginning? Why did we then go for the whole population? Was it because we thought that we could get to herd immunity? And therefore, by vaccinating as many people as possible, we would achieve herd immunity through hybrid immunity. Well, that hasn't worked because we haven't hit herd immunity. So what did we get wrong? And this is part of the problem that we're facing at the moment. Certainly public health is facing this challenge, which is that if there is no acknowledgement of an error, does it mean anything? Is it that this was an error, or has the science changed? And we're still right. I really like that because personally, I like to be right all the time. And so therefore, even when things change, I can still say I'm right. But in the real world, that doesn't work that well. So what does it mean, though, for people going forward? And here's a statement that I learned recently when I had that interview with Susan Langlois, who's a retired pharmaceutical executive working in the vaccine regulatory industry. And she raised a point that stood out to me, and everybody needs to reflect on this. Everyone is responsible. No one is accountable. And that's a problem because we all are responsible for our actions. This is something that was said before, that just know that if there are issues, you are responsible because emergency use authorization indicates that therefore you are choosing to do this. And some people would argue that they were forced to have to take it, but that's a different discussion. The point being, from a responsibility, everyone is responsible. Everyone is part of it. The problem is that no one is accountable. And when no one is accountable, it's even easier to be right. And this is effectively the situation that we are in at the moment. At this point, what does it mean going forward? How does this change impact on the people who have been following the advice? Why have the people not been following the advice? Only 0.1% per week after April. What had changed in the context of the cohort that were vaccinated that didn't make them take the booster? Where did we get that communication wrong? This has implications not just for now, and anyone who knows the research that I've been following with regards to autoimmunity will know that this is quite important. I will end, in a sense, with this very important point. In this post, in the Substack post, and so you have to join me on Substack, I ask a simple question. Why don't we have a vaccine against SARS-CoV? That's the original SARS-CoV in Asia. What is different this time? What was the reason that we were unable, and we were trying? In that post, I explain exactly what happened. Up to 2012, they tried 4 different kinds. What was the outcome that caused them not to recommend it at that point? If you don't understand the mechanism around COVID-19, the science about why it causes severe disease in specific cohorts and comorbidities, why is hypertension the leading cause in terms of comorbidities for hospitalizations? If you don't understand that science, you shouldn't actually be issuing mandates. And that's where I think the big problem is going to come back to haunt us all, is that we needed to understand the science then, and even more critically, we need to understand the science now. So for those of you who know where I am, please join me on Substack. where I share more posts, videos, and podcasts. Have a great evening.